It's a renaissance, and people are going to get a much better stone surgery with much higher stone-free rates. I'm very convinced we're on the cusp of transforming the whole stone management field in a huge way. And I couldn't agree more with Margaret. It's all about making sure patients get a better, safer, less uncomfortable experience. And let's really aim for stone-free. That's what people didn't come to us for a short operation or a cheap operation. They came to us to resolve the problem. And to me, that's CT-based criteria, stone-free, no stones after the procedure.
Hello and welcome to our WInnovations podcast. I'm your host, Dr. Kyle A. Richards, and we have a super exciting program planned for today. The purpose of these podcasts is to highlight exciting and innovative work being done at the University of Wisconsin in the Department of Urology. But for this season, we're bringing in guests from outside the department to provide unique perspectives and to highlight the collaborative efforts that are required to innovate. In fact, our guests for today are the first two people to use a new robotic technique to treat kidney stones via the MONARCH Platform for Urology. Now I'd like to introduce my guests today. First, we have Dr. Jaime Landman. Dr. Landman is professor and chairman of the Department of Urology at the University of California, Irvine Medical Center. He spent the first part of his illustrious career at Columbia University as director of minimally invasive urology before moving to UC Irvine in 2011. And Dr. Landman, I really thought was a perfect guest for our program as he's recognized as an international expert in kidney disease, including kidney stones, cancer, and obstruction, having pioneered techniques and technologies for minimally invasive management of kidney stones and kidney tumors. Welcome to the program, Dr. Landman.
Oh, thanks, Kyle. I think your introduction was way too generous, but I appreciate it.
And Dr. Margaret Knoedler. She's an assistant professor of urology at the University of Wisconsin, where she joined as faculty in 2022 after completing her urology residency and endourology fellowship at the University of Wisconsin. Prior to that, she was a medical student at Tulane. And Dr. Knoedler is a rising star, and under the tutelage of our chair, Dr. Stephen Nakata, has quickly ascended to chief of endourology at UW. I know both of our guests are really passionate about improving the technologies we use for kidney stone surgery. As a urologic oncologist, by training, I'm eager to learn from them today. And it's truly amazing to have both Dr. Landman and Dr. Knoedler in the studio to discuss the topic for today, which is the evolving landscape of minimally invasive kidney stone surgery. I forgot to give Dr. Knoedler a chance to say hello.
Thank you for having me. I'm very excited to be on WInnovations for round two.
That brings up a good point. She was on for our first season as well, so she's a repeat guest. So thank you for being here, both of you. I just want to start out by asking, maybe we'll start with Dr. Landman, that what is it about kidney stones that really drew you to this subspecialty?
Gosh, that's an interesting first question. So, I love technology, and I loved being a doctor. I remember my father, who was a urologist, was practicing 60s, 70s, and 80s, was fascinated by the development and the evolution of endoscopes. And I still have a bunch of his rigid endoscopes with the little light bulbs on the tip. And I remember him telling me about how the light bulb would burn out. And at that point in my life, I started studying optics, and loved the stories behind it. The development of fiber optics. There's a book called The City of Light, if you're interested. And then, when we started seeing those distal sensor optics develop, the CMOS, originally CCD, and later the CMOS chips we're using today, just fascinated. So I think a love of taking care of patients and always trying to do better. And then this technology that's evolved so quickly just in the few decades that I've been doing this. I find it fascinating, and I love innovation. And we've seen so much, and I think Margaret will tell us more, but we are on the cusp of even kind of bigger picture innovations that go beyond optics and standard endoscopes.
I think that's a great story, Jaime. And what about you, Margaret? What was it that drew you to kidney stones as a subspecialty?
I would say similar reasons. I think the new technology, the ever-changing industry, and kind of the fact that that what we're doing today is probably not what we're going to be doing in 5 to 10 years from now. And it's really exciting. It means that we are always trying new things and finding better ways to treat patients and their kidney stones.
As technology changes rapidly, there's some really exciting and innovative treatments that we're going to get to. But we have to start, I think, at the even before we talk about surgical procedures for kidney stone treatment, with medical expulsive therapy. Yeah, so I wanted to sort of start with the least invasive to sort of the most invasive. And back when I was in training, a decade or so ago, Flomax was sort of all the rage, and, medical expulsive therapy for ureteral stones. Where are we right now with non-operative approaches to ureteral stones? Maybe I'll toss this to Dr. Knoedler. Since this is really the least invasive mode for kidney stone management, what's in vogue right now regarding medical expulsive therapy?
Yeah, well, there aren't a lot of medications that we give for medical expulsive therapy. The main one that we tend to give patients, tamsulosin, it's kind of the one that everybody knows of. It's the most common one that is given in the emergency department. It's actually off-label for medical expulsive therapy. So there's some data showing that for distal stones, it can help with passage of stones, but other than that, it doesn't have a lot of benefit.
And what about you, Dr. Landman? What's going on in California regarding sort of the medical management of ureteral stones?
So I couldn't agree more with Dr. Knoedler. She nailed it. The data, I think, is rather controversial if you look at the different meta-analyses. If it really is of terrible value, I'm not sure, but it's inexpensive. It has low risk, low side effects. So I think we tend to do it. We've looked at it for prepping patients for surgery, trying to give alpha blockers and other medications prior to surgery to try and get the access sheath up better. We have a force sensor that Dr. Klayman developed. So we've not seen massive improvement with pre-treatment. We've not seen tremendous improvement after. I still tend to use it because I think it can't hurt and it might help. I think there's a lot of exciting things going on. We're doing some research on different drugs in the lab. Again, using the force sensor, we can really establish if there are changes in the tensile strength of the muscles and the force required to take up access sheaths and other instruments. But I think it's stagnated a little. We were all super excited about it when it first came out, and now I don't think there's much data supporting the yay or nay perspective.
Yeah, that's interesting thoughts. I wanted to, sort of move on then to shockwave lithotripsy. I think the history of shockwave lithotripsy, in my mind, is quite fascinating, and perhaps there are lessons to be learned. Maybe Dr. Landman, can you comment on how shockwave was developed and how it came to fruition, and sort of what its role is currently in 2024?
Well, I'm glad you asked me all the old man questions. It really makes me feel great about myself. Thanks. I think
the wise man.
Well, just old, not wise. I think originally it was the Russians who noted pitting on the front of their aircraft. And then the idea was that shockwaves could actually have significant damage to solid structures. And so Dornier capitalized on that. They built the first HM3. Forgive me, I don't remember the actual year. It was in the 80s, I think. The HM3 was that classic machine that you've probably seen pictures of. It was a huge water bath, had a gantry. You'd take the patient, drop them in. At the bottom, it basically had an inverted salad bowl that was the reflector that would focus what was a spark gap. So you had literally a spark plug. And I worked at WashU, and Ralph Klayman had started a system there where everyone focused all their cases there. So as a fellow, we did hundreds of them. And it was an incredibly effective machine, like insanely effective. And I think you might have been hinting at this. This is an idea, a real kind of technology where sadly we have taken massive steps backwards. So we had an incredibly effective machine, and then everyone's like, gosh, it's such a pain in the ass to get the patient into a bathing suit and drop them in this water, and it takes time and it's slow. Hey, why don't we just take a piece of gel and just whip through this procedure? We can do it faster. And maybe we don't need anesthesia because we're going to use less power and, change F2, and it's not going to be cigar shaped anymore. And the bottom line is we took a really brilliant step forward that it was almost magical in its minimally invasive progress. And I hate saying this because it's going to probably annoy a lot of shockwave lithotripsy machine manufacturers, but we've taken massive steps backwards. And, you can say, I'm going to argue that point, but you can't. Look what's happened. If you look at ESWAL statistics, we're doing so much less shockwave. Why is that the case? You can still get out decent outcomes. You still minimal morbidity. You still can bill and collect for it. So urologists still like doing it. but it's just not effective. And I think urologists don't like procedures that are ineffective. So we've kind of destroyed what was initially a beautiful technology and diminished it. And what's taken over is ureteroscopy, because ureteroscopy, per our initial discussion with advances in technology, the optics are better, the flow is better. We have better adjunctive technologies, and nitinol's gotten really cool. Oh, yeah. So now we can do more ureteroscopy. Step backwards, in my opinion. I'd love to hear what Margaret has to say about it.
Yeah, well, I will say that I have seen that machine. I have actually seen that shockwave lithotripsy machine, and we used it when I was a med student. So it is still around in some places. And yeah, I mean, we looked at the Medicare data, and it, I think if you ask like the new residents coming out, they would say, oh, everybody does ureteroscopy for everything, for every stone. But when we looked at the Medicare data, it really wasn't until 2017 that ureteroscopy surpassed shockwave as the most common surgery for kidney stones. And I think it still has a place. I think if you ask a lot of physicians and a lot of urologists which one they would choose, at least kind of polling my colleagues, a lot of people would pick shockwave. So I think even though the trend has been towards ureteroscopy, I think it is still important to know that shockwave is an option, and it is a good option for treatment.
And I have to agree with you, because quite frankly, you are at the site. I think you were, meaning Wisconsin was the site where the skin to stone distance concept was engendered by Dr. Nakata. And if you follow the Eswell rules, skin to stone distance, less than 10 centimeters, you check durility and it's a relatively softer stone, and you stay to relatively smaller or 1 centimeter less sized stones, you're going to have reasonable results, even with the diminished machines that we have today. But I think sadly, we see a whole lot of patients who don't, they follow the rules. Their urologists may not be following the rules and stretching those a little bit, and then you don't get great outcomes.
Yeah, I also think a lot of our patients don't fall within those ideal guidelines too. Love to have a practice of ideal patients, but that doesn't really exist. So.
And perhaps there's some referral bias at the academic centers where you're, getting some of these more complicated stone cases that are not good cases for shockwave. So our residents are a little bit maybe tainted in sort of what they see. And patient selection is also critical, I think, is what you guys are pointing out. I think that was a nice discussion on shockwave lithotripsy, and I think now would be a good segue into ureteroscopy. So, Margaret, maybe we'll start with you on this. What are some things that are new and exciting in ureteroscopy that you're really looking forward to and offering your patients?
Yeah, I think there is a lot of innovation in the area of ureteroscopy right now. So it is a very exciting time to be in the stone world. I think some of the things that I am really excited about are some new sheaths, some new ureter scopes that kind of increase our ability to suction out stone fragments. So Calyxo just came out with a new ureter scope that you can suction out fragments while you're treating the stones. And I think that is kind of one of the big innovations that we're going to see, is not just treating the stones ureteroscopically, but also being able to efficiently remove the fragments. One of the other sheaths that I think is really interesting is the clear Petra sheath, which has suction attached to it. So, a similar concept, but kind of suctioning the stone fragments out through the sheath, not through the ureter scope. And it's got a flexible tip to it, which allows you to kind of guide the sheath into the different calyces and remove fragments that way. So I'm hoping to see, improved stone-free rates after ureteroscopy with these new innovations that are coming out.
And Jaime, I guess Margaret brought up the stone-free debates. Are you a basketer or a duster? Does every fragment matter? Where's your stance on that when you're doing ureteroscopy?
Well, So I'm going to take a step back, if you don't mind. So I just could not agree more with Margaret. I think the aspiration, whether it be a catheter or these new endoscopes, is the future. And when you really take a bigger picture step back on innovation, what we're doing today is beyond dumb. If you look at the force vectors, you have an endoscope, you find the stone, and then you fragment it, and simultaneously you're irrigating out the scope and you're blasting the fragments all over the place, making it almost impossible to pick up the fragments if you're a basketer, or dust them. You have to find everything if you're a duster. So to step back, it doesn't really matter if you fragment or dust. I strongly believe that basketing is better, but people will disagree with me. I think the aspiration thing is disruptive and transformative, and we're just figuring out how to do it. And we'll evolve this conversation into the MONARCH robot. But I do believe that aspiration and the concept of simultaneously aspirating while we're fragmenting, particularly with the novel lasers that can be set to make smaller fragment sizes, is going to take us from a current standard that is god-awful with regards to true stone-free rates and get us to something that hopefully is less embarrassing and less a stain on the urologic community, which is a 55% stone-free rate by the very best people in the world doing ureteroscopy. And then with regards to basketing versus dusting, I think I already answered the question. I like to fragment, and we get up 14, 16 access sheaths in 60% of patients without any injuries using a force sensor. And with that, I can usually break stones into relatively large chunks and drag them out. But then again, my stone-free rate is no better than 55%, with the CT-based criteria. And we're working really hard to do a good job.
And can you just elaborate maybe for the patients and maybe the urologic oncologists that are listening what a force sensor is?
So this is just an experimental device right now, but it's literally just a tensometer. We push against the access sheath so you know exactly how much force you're putting on when you push it up. And there was our paper, and right around the same time, a Korean paper came out that says if you stay under 7 newtons, it's 6 or 7 newtons, the chance of causing a ureteral injury is almost zero. So when people are afraid to put up an access sheath, well, it's because we don't push as hard as we should or too hard. And we've also proven that. We did a nice study we presented at the AUA, where we had urologists test what their force was. And we did this at different meetings, World Congress and AUA. And 1/3 of urologists push way too hard and will cause injury. 1/3 of urologists push way too little and won't get up the biggest access sheath they could. And about 1/3 of urologists get it into that kind of 4 to 6 Newton range where they're going to optimize the access sheath they get up. And Dr. Klayman's working really, really hard with VTI, a company in Boston, to try and create a commercially available access sheath. But we're fortunate enough to be able to use a very advanced version, a digital version. And that's why we can put up the bigger access sheath safely in 60% of people. And with that, pull out some big honking fragments.
Fascinating work. And that's being commercially developed at some point. Is that the hope?
We're trying, but translation is often difficult.
Yeah, it takes time to get that to marketplace, I'm sure. And then just a follow-up question for you, Dr. Knoedler, with these aspiration technologies, my assumption is that's not going to just lead to increasing stone-free rates, but also faster surgeries?
Yeah, I mean, hopefully. So I'll say I am in the dusting camp. So I am mostly dusting when I'm doing ureteroscopy. And I love the idea of dusting a stone and being able to aspirate out all the fragments instead of basketing them out. And I think that in the dusting realm, it would have a big impact to be able to aspirate out the dust particles. I think it'd be better visibility while you're doing the case so that you can find those smaller fragments that might be left behind. So even though you think you're stone-free at the end of the case, you might be missing some things if there's poor visibility. And I think aspiration will help with that as well.
Jaime, how do you feel about the disposable ureteroscopes? Are they worth a look, worth using? Too early to say?
Well, gosh, you're hitting all my pain points. So, disposable endoscopes were engendered largely because of the infectious complications that the GI folks saw. And remember, they're sticking their scopes in the areas of the body where they literally have the highest bacterial concentration. There's nothing higher than your rectum, your sigmoid, and the left, the descending colon. So they had some real troubles. The disposable endoscope was introduced in urology based on that concept. Recently saw a manuscript, forgive me, because I don't know if it's been published or not published. As the editor of the Journal of Endourology, I get confused very easily because I see a lot of stuff where they actually put a really positive spin on it. We have absolutely no increased infections with the disposable scopes. I'm like, well, aren't you supposed to have decreased infection rate? And if that's the whole point, I don't know. I find people are making very interesting arguments regarding the cost, and you can always manipulate numbers, but it's hard for me to believe that buying a whole new endoscope is cheaper. There's been interesting articles showing that they're less impactful to the environment. I have trouble believing when I throw 5 pieces of plastic into the dump at the end of a day in the OR, along with all the paper and plastic in which it comes, that's more efficient. But people like it. It's not a trend that you can fight because it's just happening. Even the kind of stalwarts like the Carl Storzes, who are slow and they make beautiful equipment, but they're really slow and they really believe in what they're doing. Now they have a disposable. Pretty much everyone does. And there is something nice about, picking it up. Just it's new, it deflects great, it's got great optics. You can abuse it and not worry about, broken components that require major repair. It's really nice. It's easy. I've never done it, but they tell me snorting cocaine is also really nice. It feels good, I'm kind of like, I want my old scopes, but it's a trend I don't think you can fight. It's just happening. It's happening for the wrong reasons. Unless, Margaret, you can convince me that there's some really good reason to use them, but I'm just not getting it.
Yeah, I will say I don't really use disposable ureteroscopes very often, so I'm kind of in the same boat. It is interesting looking at the environmental impact. I know there was one paper kind of comparing the two when they looked at like the carbon footprint, the carbon emission, and they kind of said it was equivalent for the disposable ureteroscope versus the reusable. I mean, I think the most eye-opening thing about that analysis was looking at how much waste there is with reprocessing our equipment. I mean, obviously we want to make it as safe as possible and as sterile as possible. So we go through a lot of reprocessing cycles. But I think whether you use the disposable or the reusable, every time you're going to the OR, there's a lot of waste. So yeah, I don't think either one is environmentally friendly, and I think you probably just need to go with the scope that works the best.
Those are all great points. I was glad to sort of ruffle the feathers of Jaime a little bit. That was not intentional, but it means I'm hitting some good talking points. I have to stay educated on this stuff too as a urologic oncologist. So Margaret has been very helpful in keeping me up to speed. But I do want to switch gears. I think we hit a lot of good points on ureteroscopy and move towards percutaneous stone surgery. There's a lot, I think, to talk about in this realm. And I think a lot of technology, from what I've been learning from the endo team here at University of Wisconsin, as well as from some of my colleagues around the country. And I want to start with sort of just getting access to the kidney. I know there's different schools of thought between, ultrasound versus fluoroscopy guided. Where are you at with the initial access point, Dr. Landman, as far as any sort of technological advances in that realm?
Well, I think ultrasound should no longer be considered an advance. I think a lot of people are doing it. We're using ultrasound. The only thing that you hadn't mentioned is, we like to do things under direct vision. So putting a ureteroscope into the calyx, the desired calyx, is very helpful from my perspective. Quite often, not quite often, but every now and again, you get up there, the angles are just great, and you decide that something that was a PCNL can then be done ureteroscopically and still keep it effective. So that's one advantage of putting in the ureteroscope. The second thing is you can really see the width of the infundibula, the different angles, and get a feel for where you should stick the kidney. And then whether you're using fluoro or ultrasound, having the ureteroscope as a kind of dense foreign body inside the kidney really facilitates, for me, access. And I am beyond dyslexic, so I need a lot of help with access. And having the ureteroscope there helps me both ultrasound and with fluoro. So that's my 2 cents. What do you think, Margaret?
I mean, we use a combination. I've liked experimenting recently with kind of direct vision, fluoroscopic guidance. We use mostly fluoroscopic guidance at UW. But I mean, I think ultrasound is great and it definitely has its place. But I think sometimes just going old fashioned and fluoroscopic guidance can be very effective and quick. So I think one advance, the electromagnetic guidance for access, which is what we would use with the MONARCH system, has been very easy to use and has really simplified access as well.
Yeah, I think we can segue to the MONARCH Robotic Assistance Platform. Jaime, maybe we'll start with you then. How did you get involved with sort of the clinical trial to study this platform?
So I got involved, I think it was 7 or 8 years ago. I had some extra time on my hands. And so I was talking to Fred Moll, who's a good friend. He's the guy who started Auris. And he asked me to take a peek at the robot and its development. And Mihir Desai was working on it pretty hot and heavy. A lot of people were. But I got really interested in it. And it was such a fascinating project that I ended up spending a lot more time than originally planned on it. So I just got deeper and deeper because it was super cool, right? Developing that EM system, which, by the way, they developed it. I didn't do it, but testing it with the original graphic user interfaces that were a little bit crude. It was just so cool and so much fun. Kyle, and I think Margaret already said it, but it is so intuitive. It is so brilliant that even a urologic oncologist could gain good access to the kidney. Even you, my brother, could do it. And
hallelujah.
And that's, I think, the major stumbling point for most urologists in not doing PCNL is that getting access is hard, right? It's a skill set that's hard to evolve. And if you rely on your friendly radiologists, the data is very clear. Your access is just not as good. Your stone-free rates are not as good. Your complications are higher. So you really got to do it yourself. And this is a disruptive, transformative technology.
Margaret, maybe you can then talk a little bit about how the procedure is performed. And is radiology typically involved in the early phases, or how is that going?
For MONARCH?
Yeah.
Radiology is not involved with our MONARCH cases. It's a very interesting new kind of approach to PCNL. So you start by getting ureteroscopic access, and then you pick the calyx that you're going to get percutaneous access, and then using the electromagnetic guidance, you guide the needle into the percutaneous access position. And then the percutaneous access is actually a suction catheter. So you're treating the stone ureteroscopically with a laser and then sucking out the fragments percutaneously. So I know earlier we were kind of talking about the improvements with ureteroscopy and suctioning out fragments and how that's really going to improve stone-free rates. And, it's kind of a similar approach here, but with a percutaneous sheath and percutaneous suction catheter, which, is a lot larger than what you can use ureteroscopically. And so it does a really great job of sucking out all the stone fragments.
That's fascinating. Really paradigm shifting, certainly a new way of thinking about managing large renal stones. Can you sort of sum up the advantages that you would potentially see from this then, Jaime? Obviously, I've heard you say that this would be potentially better access, more controllable by urologists, but what are some of the other advantages you could foresee from this technology?
Right. Well, the access is a good one. Just to give you an example, in 13 out of the 13 cases that we did in the trial here at UCI, we got single stick access within 2 millimeters of the tip of the papilla we were aiming for. And every one of them was dead parallel to the infundibulum. So it was what I would call perfect access. And, despite 20 or plus years of doing PCNLs on my own, I can't do that with fluoro ultrasound or anything else. So access is great. The aspiration thing, we were talking about it earlier. I think it's transformational. The idea that you're blowing your fragments around as you're creating them just seems really dumb in retrospect. It's not dumb if you don't have an alternative, but now this will be an alternative where as you're creating the fragments, they'll be aspirated out in real time. And the suction catheter, to some degree, does also keep the stones right in the same place because the fragments just hover around the suction catheter, which is really kind of fun to watch. What people have not realized for generations now is that pressure flow dynamics are critically important. And that's why I've always been in love with the access sheath as well as dual lumen ureteroscopes, because you get much better flow. And there's nothing more frustrating than a beautiful field where everything looks great, and then you put in your basket or your larger laser, and then things look awful because your flow went away. So this is also another situation where it has a dedicated fluid management system, which includes the suction catheter that we've just been talking about. But around that goes the irrigation, which comes through the sheath outside of the suction catheter. So you can put anything you want through the ureteroscope lumen, and it's a single lumen, but you're not compromising your irrigation. And we're going to do the studies. We haven't done them yet, but I think that the intracavitary pressures should be, at least in theory, so I don't have data, but in theory should be lower as you're irrigating, you're simultaneously aspirating most of the time. So I think that'll be safer. And I think as a gestalt, all of that should make this superior. Now, I'm not going to make that claim because the data doesn't show that. Our first 13 cases were probably just as good as we could have done with standard PCNL. But keep in mind, I'm a slow learner. For real, it takes me time to get onto a new technology. And that was my first 13 cases. I did 11 of them. Mihir did 2 of them. And I think I would get better. And I do miss the machine. I'd love to hear Margaret's thoughts. But now that they've taken it away from us and we won't get it back until it's commercially available, I miss it.
So I'm hearing you say there is a little bit of a learning curve. What do you think, Margaret, after doing several cases? What do you think the learning curve might be for this technology?
Yeah, great question. So I think I've done 8 cases so far, and they have been very fun and interesting cases. Now, I agree that it probably at this point has not made the cases faster than the standard of care cases that I do, but it is a very fascinating way to treat the stone. And I think that it is very efficient to kind of suck out the stones percutaneously as you're treating them. And so I think that once I've kind of gotten completely through the learning curve, it'll be very fast, efficient cases.
That's great.
Of the learning curve, Kyle, the companies invested an enormous amount of money on a virtual reality simulator that uses the exact same handheld controller we're using. And I got to tell you, I think that thing is really going to facilitate the learning curve. You got to remember, and I freely admit this, I'm a great guy to throw new technology in because if I can do it, anyone can do it. And I mean that very seriously. So I think my children could pick this thing up much faster. They're already used to using, what is this thing? It's called an Xbox, right? Am I right? A controller?
Yeah, my children have used it.
Yeah.
They like the simulator.
Yeah, so the simulator is gorgeous. It really teaches you the use of the buttons and gives you a feel for it. I think if I had that simulator before I had done my cases, that my learning curve would have been facilitated.
Wow, that's really cool stuff. I think we've covered a lot of ground so far, talking about medical expulsive therapy, innovative things in ureteroscopy. Talked a little bit about how Shockwave maybe has taken a step backwards. Certainly in correct patients, patient selection is key. And then we had a really good discussion on percutaneous stone surgery and certainly the innovative things coming down the pike with that. So for maybe I'll turn this to Margaret then. For patients tuning in, which we oftentimes have patients that listen into these podcasts, I know this is kind of a broad question, but what would you want them to know about exciting things happening in kidney stone surgery in 2024?
I think I would like the patients to know that we are continuing to put all of our efforts towards making better, safer surgeries, less invasive, less discomfort after surgery, and that we are continuing to improve all of our processes.
What about you, Jaime? What do you think?
Reflecting on what we've been discussing, I'm a crotchety old guy and I'm complaining a lot. But the truth is, if you look at where we've gone from where my dad was treating people with big open surgeries I did in my residency some open surgery for ureteral and kidney stones. And that was horrific. And leaving a Penrose so that people could urinate out their abdomen into the wound for a week before it dried up was just awful. So we've seen massive improvements. The endoscope stuff we talked about at the beginning is just transformative. When I started, if your flexible endoscope even deflected a tiny bit, you were very impressed. And now they kind of do gymnastics. The optics are better. We have pumps and flows. We have better nitinol equipment. We have better lasers. And per what we've discussed today, I really think that this aspiration thing, be it manual or with the MONARCH robot that hopefully will be out sometime in 25 or 26 as a kind of commercially viable product, it's a renaissance, and people are going to get a much better stone surgery with much higher stone free rates. I'm very convinced we're on the cusp of transforming the whole stone management field in a huge way. And I couldn't agree more with Margaret. It's all about making sure patients get a better, safer, less uncomfortable experience. And let's really aim for stone free. That's what people didn't come to us for a short operation or a cheap operation. They came to us to resolve the problem. And to me, that's CT-based criteria, stone free, no stones after the procedure.
I think that's very well said, Dr. Landman. I think we've hit all the high points that I had on the agenda. Did we miss anything, Margaret or Jamie, anything that we're leaving out that you're really excited about that's coming down the pike for innovative approaches to kidney stone management?
No, we could do B-roll for the low points, but I think you hit a lot of high points. You did a great job, and it was a real privilege to participate. Thank you so much.
And Margaret?
Yeah, thank you, Kyle, for having us.
Yeah, I want to thank you guys. This has really been a lot of fun, and I certainly, as a simple urologic oncologist, have learned a lot. So I appreciate learning from both of you guys. I want to thank our producer and editor, Sandra Miller. I also want to thank Stephen Nakata, our chairman and thought leader when it comes to all things kidney stones. And of course, I want to thank all our listeners out there for tuning in, and so long.
WInnovations is a production from the Department of Urology at the University of Wisconsin-Madison School of Medicine and Public Health. Thanks for listening.